Sir, we are live. We can go ahead.
Shall I start? Yeah.
Yes, you can please go ahead, sir.
Thank you.
Of course, 75 people now joined.
Yeah. So good evening to all of you. It's always a pleasure to speak to our colleagues in the nursing fraternity, as nobody needs to be reminded that our nursing colleagues are the backbone of our profession. And it gives me great pleasure to welcome all of you today on behalf of Microlabs and AHPI-ANEI to talk on this multidisciplinary team approach for reducing medication errors. All of us, of course, know that medication errors are a significant problem in healthcare today. And they can and do lead to serious consequences, including hospitalization, disability, and sometimes even death. However, by working together as a team, we can reduce the incidence of medication errors and improve patient outcomes. This approach brings people from different areas, nurses, doctors, pharmacists, to collaborate and coordinate care for patients. And by working together, we can identify potential medication errors, implement strategies to prevent them, and ensure that patients receive the right medication at the right point. I'm not going to talk too much of that. You've got a panel of experts from all over the country who are going to talk to you. I just want to add one point, and which I want to emphasize on. I think this is of the role of communication. I think the role of communication is so very crucial, especially in the nursing communication and nursing the profession. It is important for promoting collaboration and teamwork among healthcare professionals. And our nurses must be able to communicate effectively with doctors, therapists, and other members, as I just mentioned, to ensure that everyone is working together to provide the best possible care for patients. Effective communication, I think today you may not hear much about it, so I'm just going to add my 2 bits. Effective communication is essential for nurses to provide high-quality care and promote positive health outcomes. By developing strong communication skills, nurses can build trust with patients, promote patient safety, and work collaboratively. That's what we're going to see today with other healthcare professionals to provide the best possible care. So today's talk with all the experts, we will discuss the benefits of the multidisciplinary team approach, the different roles and responsibilities of team members, and strategies for effective collaboration. I think the speakers, all eminent, are going to take you through a very, very interesting approach and also informative one. And I hope that all of you, by the end of this talk, will have a better understanding of the importance of teamwork, the crucial role of communication in reducing medication errors, and the role that each of us can play in ensuring patients' safety. So thank you all once again, and I'm sure that you will be looking forward to an engaging and informative discussion. And once again, I want to thank Raja and team for organizing this program, which is going to empower our nursing profession and others involved. Thank you very much.
Thank you. Thank you, Dr. Alexander. So my name is Saino Thomas, and I work with CTSI as a Group Chief Nursing Officer, working for American Oncology Institute and Citizens Hospital. Today, I will be moderating the session, and it's my prime privilege to work along and associated with AHPI-ANEI, with Microlabs, and thanking these fraternities to help us out to create this platform and have series of webinar all through this wonderful, pleasant time of the year where we celebrate nurses. And thank you so much for providing this platform. Today, we have a very important topic, multidisciplinary team approach to reducing medication errors. We have panelists here who are all senior resources. And if you see the dynamicity of this group, we have looked at the resources from different specialties. because medication management is not just only nurse's role or doctor's role. May I take this time to welcome all our panelists. I would welcome Dr. Abbas, who is the Regional Director, Medical Affairs for American Oncology Institute, Central Region. Dr. Abbas, we welcome you. Thank you so much for giving your time and being here. May I take this time to welcome Ms. Madhavi Chikhale. I hope I pronounced you right. She's the Chief of Nursing for Fortis Mohali Hospital, Punjab. Welcome, Ms. Madhavi. Thank you so much for providing your time to us. I would now welcome Ms. Leena Chandrasekaran, Head Nursing Operations, Mehta Multi-speciality Hospital Private Limited from Chennai. Thank you so much that you are here. I'm sure with nursing and administrative background together, you will be able to highlight and give a lot of insight into this topic. May I now introduce Dr. MP Narmada, who is the HOD for Amrita School of Pharmacy, Kochi. With this vast years of experience, I'm sure, madam, we will be able to learn a lot of things from you. Lastly, I would like to also welcome Ms. K. Sandhya Rani, Nursing Superintendent, Fernandez Hospital. Thank you so much. From an introductory point of view on the important topic that we're discussing today, the multidisciplinary approach. In India, 5.2 million medical errors have been annually reported. The Delhi report of a very recent report, 82 out of 1,000 prescriptions are errors. So how vital and how important it is to understand and to also realize where are the places that these can be prevented. Many of or the most of the errors are basically because of dispensing is what the SAT says. But let us understand now. A patient travels from different touch points in a healthcare process, right? He comes, he gets the registration done. Once he meets the clinician prescribes medications. It goes to, if it is an outpatient, he will go to the pharmacy dispenses medication. If he goes to the IP, there again, a nurse will handle it by indenting medication, pharmacy dispatches medication, again, nurse administers medication. There are rules, policies, processes placed in terms of managing different types of medications within the system. So there are so many people who are involved and there are important touch points in medication management. Now, let us not just forget that after discharge, medication stops. No, patient himself is managing his own medication. So there are so many areas where medication errors can happen. So to take this into the right tendency, let me just start with the first question. I would request Ms. Sandhya to let us know, how can the medication related competencies become a core competency among the current workforce?
Thank you so much, ma'am, for the introduction. Now, there are very few studies which have actually looked at medication-related competencies, which can be a part of nursing core competency. But then for every nurse working in a direct care setting, preparing medications, administering them to the patients is a part of the daily routine that happens. So this is the core nursing skill that she demonstrates. So mistakes can happen at any point in the process of administration. And one of the most serious and most common mistake made by nurses is medication administration errors. The result may lengthen a hospital stay, increase the costs, or have a life and death implication for a patient. Now, looking at a core competency of nursing, it is the ability to practice nursing that meets the needs of clients, cared for using logical thinking and accurate nursing skills. Now, if we look at core competencies again, nursing core competency structure, it talks about the ability to understand the needs, the ability to provide care, the ability to collaborate, and the ability to basically support decision making. Now, when we say understand the needs, now correlating this with medication administration or medication safety, we can say understanding the needs of the patient based on the diagnosis, administering the medication. Talking about providing care is the way she administers the medication, looking after the patient, following the rights of medication administration. And then collaborating means ability to collaborate with the other healthcare providers who are also a part of the patient's care. And lastly, supporting a decision-making ability where she thinks about what is right and what is wrong. Now, coming to the next part where we talk about competent medication administration, it talks about basically administering medications is not just a technical task that a nurse does. So it requires the ability for her to assess the medication process or the medication appropriateness, where she follows the index where how the medication indication, whether the drug indication is present or not, whether the medication effectiveness, medication is effective for the condition. Such appropriateness index is looked for, and the evaluation of the appropriateness, where she measures this against the actions, the interactions, side effects, whether the correct dose is provided, whether appropriate use of the medication is used, basic pharmacokinetics of the drug, and the client's response to it.
Right. Thank you so much. Thank you so much. Yeah, this definitely is, an understanding that the collaborative perspective needs to be there as a core competency for the staffs. So when academically nurses are studying, I think this part of it should also be added on in their academic perspective, so that it is not just about giving the medicines and only pharmacology, but other aspects which are important core competencies also should become a part of it. So I'll switch on to the next question. Can I request Dr. Narmada to please highlight on the medication reconciliation process and documentation, how important it is in terms of preventing medications, and what are the things that should be kept in mind while we are looking at reconciliation process?
Thank you very much, madam. I will thank the whole organizing team, Labs and AHPI and IMM. So coming to the question, medical reconciliation, it's a very important task, and we can say it's a process. It's a systematic process wherein we can reduce the adverse medical events because of this.
Yeah.
So next slide, please. Yes. So we come across many type of errors, and as madam had highlighted, dispensing and it can happen at many levels. Dispensing errors, administration errors, or we can classify in another way also, like it could be because of the knowledge-based errors or action-based errors also. So how are we going to eliminate these errors? This can happen by taking proper medication history from the patient. So there are many errors, like they claim that at least half of the medication errors are happening at the time of admission and at the time of discharge. Because at the time of admissions, there are chances wherein if we don't take the medication history properly, we may omit the medicines which are being taken by the patients regularly. So it is a very important task by the whole healthcare team to ensure that we take the proper medication history and we account for the medication what they are using regularly. That has to be, if it is required, if it has to be continued with the consultation of the doctor, it has to be added to the prescription chart so that it is added, and at every point of time, especially when there is a clinical transfer, maybe or referred by the other departments. So whatever changes are happening with respect to medications, it has to be communicated effectively to the whole healthcare team so that the medicine which has been changed or which has been added, it will be communicated and it will be administered to the patient so that we can avoid that omission error. So errors can be omission or commission, or sometimes at the time of transcribing, that is, doctor prescribes the drugs, and at the time of transcribing, that is, the nurse or somebody, the healthcare team may rewrite the medicines in the prescription chart. There also spelling mistakes or the wrong medicines also can be written. So all these have to be taken care. So at every point of time, it has to be reviewed properly so that the medication errors does not reach the patient. Yeah. So some of the errors are very serious errors. Next slide, please. So for just to give some example, Ramipril is written by the doctor as 1.25 milligram daily, but while rewriting, it was wrongly written as 12.5 milligram daily. Yes. So you know very well it can cause a lot of complications, and it really requires immediate intervention. And then in another case, new cardiac medication was written by the doctor, but it was neither mentioned in the discharge medication nor in the summary. So it was not at all dispensed at the pharmacy, and patient got into again problems and he was re-hospitalized. So these are some just examples. Next slide, please. Next slide. Yeah. Yes. So we have to see that the communication is continuous and nowhere we miss out. And so all these errors have to be get rid of, like transcription errors, omission, commission, and duplication. And at the same time, we have to see that every time the medicines prescribed, medicines administered to the patients are accurate and they are needed, and the comprehensive medication information is followed to every healthcare team member, so that at the time of discharge, the whole list is very correct and accurate, and the information is also passed on in an educative manner to the patient, so that he understands how important is taking all the medication in the proper direction, the schedule, however it is mentioned by the doctor. So now, how to improve patient safety and how to get rid of some errors and what we can do during medication reconciliation. First and foremost is we have to collect the medication history from the patient, and we have to verify whether it is correct or not at different levels, maybe through different sources. Maybe we can see the discharge summary of the previous hospital, or we can see the prescription medication bill, or from the phone call of by the referral doctor. There are so many ways of confirming the patient medication history and what are the medications whether those medications are relevant enough to be continued in this context. All this can be accurately checked.
Right.
Next.
Yes.
Next, please. So these are the sources wherein we can take the help, and we can refer, and we can confirm the patient medication what he was taking, like patient interview, bystander, we can interview them also, and we can take community pharmacy. Supposing if the GP has prescribed some medication, those things, through phone calls, we can talk to the doctors. Maybe I will say that all this may not have much time. We cannot have much time to intervene in all these aspects. At least we have to talk to the doctor who has treated this patient previously. So that may give current information, so that we don't go wrong, at least in vomiting the medicines which have been taken.
Absolutely. Thank you so much, Dr. Narmada. I think the key in terms of the communication, which you have insisted, definitely plays a role in terms of reconciliation perspective. So in watch of the time, I will move to the next question. Thank you so much. May I request Ms. Madhavi, another important aspect where medication errors could happen and can happen, where nurses mostly play their role, is in terms of infusions. So if you could reflect on, what are the ideal precautions that they should be taking while infusions, and how to prevent the errors during infusions, and the dosages part, how can they know, what are the things that they should be keeping in mind? Yes, please.
Thank you. Thank you for the question. That's a wonderful question. And good afternoon to you all, the entire panelists. So this is something the ideal precautions that we take for an infusion preparation. So ideal situation is a big long list. So right from it starts with an IPSG goal. So where a nurse is expected to first follow that first IPSG goal, identify her patient right, check with the two identifiers, that's the patient's full name and the UHID. And these are the n number of things that she has to do. The challenge where it comes, because I would not like to enlist many, there are many multiple infusion where you need to have an infusion sticker on it, trying to say what dilution it is, what rate it is going, or sometimes it is at what drop it needs to go. So there are n number of, like if you go to list, it's more than 20. Just naming a few that which starts with which biggest mandate is checking the first IPSG goal, patient's name, and the UHID against the patient's, against the doctor's prescription that we have. That is the first thing that we do. The second part is the verification of the orders, because as we see currently in the operational load, many a time we see that the nurses do understand the basic calculation, they do understand the basic maths. If 500 ml of fluid to give in over 8 hours, so they divide it accordingly. So when you go to the breakdown of it, there is a little knowledge of it. So which is like where the academicians and onboarding program actually takes care of it. So many a time nurses come to us that, how do we go ahead with this? How do we? So they are not even aware that there is a drip factor, there is a drop factor in a macro set, in a micro set. So this is where we have to actually work from, right from there, where we teach the nurses, where we have ideal infusion charts prepared, standard infusion charts for the regular medications that are being placed over there. And the second part, which is a very important part, after having all these ideal things that we speak about, we need to have a verification, a stage where the nurse, there is a second verifier. You know, we only talk of verification for a vulnerable group. But currently, the way that we have our scenarios ongoing with the nurses, we had a COVID batch coming in. We need to have a second verifier to ensure that the infusion, because again, infusion is a direct intravenous medication that we are giving. So the knowledge for the nurse to have, where we are giving a privilege to do that, this part should be very much taken care of, where the second verification helps us a lot and actually clears out into the main preparations required during the IV part of it. And the last but not the least, it is the pre and post documentation for the IV infusions. So that's about it.
Thank you, Ms. Madhavi. I think it definitely plays a very important role. Infusions may be a single infusion. It could be multiple infusions during a central intervention as well. So every single time an infusion has been started, all these aspects have to be kept in mind. Now, it's not just at the beginning of the infusion, but it's between intermittent infusions and even when you have intermittent flushings happening, these have to be kept in mind, because anything which is going in situ into the body is definitely need to be looked into. Thank you so much.
Rightly said. And where I'm so sorry, I need to add this part. There is where our nurses need to also be aware of the VIP score. Yeah, that is very, very important during the intermittent monitoring.
Absolutely. Yeah, absolutely. Thank you so much. Let's also look at another perspective in terms of the look-alike and sound-alike medications, because manufacturing control is not in the hands of all the healthcare workers. It's just given to us, right? So can I request Dr. Narmada to please highlight what are the things to be kept in mind when we are handling or high alert medications as well as look-alike, sound-alike medications? Yes, please.
Yes, madam. So look-alike, sound-alike drugs, they look many in an appearance, color-wise, shape-wise, they all look alike.
Right.
So these medications, they also cause a lot of errors. Next, please. I'd like to just go for some examples. Yes. So if see, while prescribing or while rewriting, if we say just cefotaxime, we may start writing CEF. By the time we write these 3 letters, many such medications list will come out. So it will be very confusing to see cefotaxime, ceftazidime, cefuroxime, ceftriaxone. All these are similar spelled names, and while pronouncing also it may look. So we may go wrong. So what I would say, this is all happening. So here what we can do is, we can see that the nurse who is administering can get it counter-checked by the supervising nurse, and also it can be counter-checked by the pharmacist around there. So in the ward, there will be clinical pharmacists, so they can verify whether the medication what has been picked up by the nurse, is it correct or not in terms of dose, in terms of route of administration and the direction, in all these questions. Then this can be done. Then what are the other strategies we can do is, like we can develop computerized configuration so that when we type some letters, they don't bring out the similar spelled names together. So that because when it is together, there is a chance for clicking that and picking up that medicine. So that can be generated, and we can use artificial intelligence also to see that these medication errors are eliminated from the system. And for some examples, say doxorubicin, daunorubicin, idarubicin, all will almost they sound alike. So we have to take care. So that here I would express my feeling that the time of administration, at the time of picking up of medicine, whether it is a nurse or a pharmacist, whoever may be, let us devote 10% dedication and attention, because it is the patient who is in front, and we cannot cause extra harm by just giving wrong medication. So let us be more careful. And coming to the brand names, the Adderall, Inderall, PD-Mox, all they look. So here at most care is required while picking up and administrating, and at the same time it should be documented, and that documentation also has to be verified by the pharmacist and the nurse, so that we can eliminate errors. And when there is any inquiry also, we can show that documentation, so that if there is anything anywhere we have committed mistakes, it should be traced and it can be taken care in future.
Absolutely. Thank you. Yes, very important aspects across, when it comes to LASA drugs, the lookalike, sound-alike creates a lot of confusions. In fact, in storage areas as well, when we are keeping these medications as well, there has to be some rationale in terms of not keeping it together, where those drugs have been taken out, and it's easy and handy. Also, when you are arranging the medications in your place, have a little bit of standardized way of arranging it so that a newcomer doesn't find it very difficult, specifically when you're floating people from one area to another area. They don't find that confusion in picking up medications and doing that error. So these are also things which we should keep in mind. And let's come to a very interesting question which all nurses will like. How much should a clinician and what are the important aspects from a clinician's point of view, that should be kept in mind while prescribing and any other role which a clinician plays in reducing the medication errors? I'll request Dr. Abbas to highlight on this aspect, please.
Thank you, ma'am. Ma'am, basically most of the things are already covered in this. But I would like to mention basically the things where the clinicians are involved in these steps. So the medication error may occur at any stage of medication management. It's a complex process, and it has got several steps. So errors can occur at such as selection of medicines for formulary, storage, distribution, prescription, reconciliation, dispensing, administration, and use by the patients. So where the clinician is involved. So clinician is involved in prescribing the medicine. Second, transcribing the medicines. Third, implementation of verbal orders. So these 3 points comes when where the clinicians are involved, clinicians and the resident doctors.
Yes.
So if the writing of the clinician is not legible,
correct,
then also it's very, very prone to medication errors. Right. If resident doctors did not transcribe properly in the medicine chart, right, then also medication error can occur. And if the doctor did not properly communicate it with the resident doctor or a nursing staff, so verbal order was not properly communicated, so that also can cause the medication error. So what we have to do to improvise all this? So we have to first write in a capital letter, prescribe the medicines in a capital letter, and using Tolman lettering, or not using abbreviations. So this is what we need to do to minimize the prescription errors. Transcription errors can also occur. So resident doctor should doubly check the transcription, the medicine which he had transcribed in the medicine sheet. So that has to be checked twice. And the verbal orders should be, there should be a policy in the hospital that verbal order should not be entertained. But in case of emergency, sometimes it occurs that clinicians are not available and the resident doctors has to communicate with the senior consultant, and they have to take the verbal orders. But it should be reconfirmed within 12 hours, and it should be double checked. So these are the things which can minimize the medication errors. So this is one.
Right. Thank you. Thank you, Dr. Abbas. Of course, a lot of important aspects, which are very common ones, but these are the real ones which are, leading and which are very preventable. If you look at it, errors are preventable. So these should be kept in mind from a clinician point of view. Thank you so much. Also, nurses needs to be assertive as well. When you are finding it very, difficult to read, you need to question it back. When you have a verbal order, you need to stand on to the policy. This assertive perspective in terms of the policies which are in place needs also to be implemented for us to be safe at all given point of time. Thank you. May I also now look at another element which is important from a medication safety point of view, and that is patient education, right? Sometimes we feel that once the patient is in the hospital, it's only the healthcare workers responsible for the medication safety. But ideally, a person who is taking the medication also needs to be involved into it, right? So how much does patient education requires, or how much is the counseling playing a role? I request Ms. Sandhya to highlight on these aspects, and how much and how should this be incorporated in the day-to-day communication style of nurses to reduce medication errors?
Yes, ma'am. So providing patient with complete and current information actually helps to create an atmosphere of trust between the patient and the nurse. And this actually empowers the patient to participate in their own healthcare. So looking at how preventing adverse events or how to prevent events that happen at home after the discharge, we need to concentrate on three most important things. The first is the medication reconciliation, which has already been discussed. Second thing is structured discharge communication. That means information regarding medication changes, pending tests and studies, regarding the follow-up needs that the patient needs. Those should be properly communicated to the patient. And lastly, patient education. Now, patient education as such is a whole aspect which we need to concentrate on, where the patient needs to understand his or her diagnosis, their follow-up needs, their medication history, the medications that they have been taken before, and the medications that are added up now. So to talk about this in detail, actually, there are 5 moments of medication safety after the patient is discharged. The WHO speaks about it, where it talks about how a patient starts a medication, how he takes his medication, adding a medication, reviewing his medication, and lastly, how the medication is being stopped. So all this process, these 5 moments he needs to follow in order to have a safe practice even at home. And then more concentration on effective use of their medications. For example, he should understand why he's taking the medication. For example, he has nausea, and then he is prescribed a medication. He should understand that that particular medication, MSET or whatever is written, is for his nausea or vomiting. Similarly, talking about drug interactions, patient needs to know that drugs do have interactions with drug-to-drug, food-to-drug interactions, or drug interactions with beverages, and they should understand that they will also have an adverse effect on the patient. And lastly, some patients, after going back home, they prefer herbal medications or Ayurvedic medications. They need to understand that there is a difference, and they need to follow certain criteria to stop allopathic medications and start on their own Ayurvedic or herbal medications. Yes. So I think these are the main points that we need to touch when a patient is basically being counseled or educated prior to discharge.
Very true, very true. A mix of multiple things in the body will definitely be effective. People don't understand that they need to be very crystal clear, and then that different modalities do react with each other. They need to be very safe in terms of practicing. Over-the-counter medications that people take is also something which is very important. We should make people understand this. I think from the Indian habit point of view, you have somebody who knows things, and and you ask them, you prefer not to go, even though we have a very free healthcare setup. But these practices do make a difference when a patient is undergoing certain conditions. And then when also there's a habit that the patient has been taking certain medications with time, 1-2 years, when they are habituated to being taking them, then it becomes a part of the routine. They don't understand that actually it is a medication. So they, so it's very important to educate patients. Thank you so much, Ms. Sandhya, for highlighting that. I would also, look at an element which once the medication goes into the body, there are this is basically for the treatment purposes, but not all bodies react the same way to a medication. So there are adverse drug reactions which do happen. So the nurses need to be aware, the same medication can react differently on different patients. At all given point of time, the same dosages and the same type of drugs. May I request Dr. Narmada to highlight on the perspective of what are the aspects to be kept in mind, and how prompt a person should be while handling the ADR part? Yes. Or the adverse drug reaction.
Yes. So this adverse drug reactions comes under the topic of pharmacovigilance. We have to be vigilant enough to understand, to observe the reaction, and immediately we have to manage the patient from that adverse drug reaction. So adverse drug reaction, we say, like, it can happen with any drug which has been administered or taken by the patient at its normal dose. So normal doses itself can cause adverse drug reactions. Maybe it is because of the patient genetic or he is quite hypersensitive to, so he may be allergic to normal doses even. Whereas there are even another term called adverse drug events. So this can happen, and this can be very much prevented. So adverse drug reactions and adverse drug events, that is a little different. And adverse drug events are preventable, and it can be under the control of the healthcare team. So wherein we can find because of the wrong communication or wrong selection, this can happen, and we have to highlight. And the duty of the healthcare team is to observe the ADR very quickly on the spot, and it has to be communicated to the whole team. And it is better the pharmacist observes the reaction, because there is a format of reporting this reaction to CDS-CO format. It is Central Drug Standardization Control Organization. They have a format. Here, ADR can be reported by everybody, not only the doctors, everybody can report. Doctors, nurses, pharmacists, even the patients, bystanders, everybody has a right to communicate this to Pharmacovigilance Center of India. And we have so many peripheral centers and zonal centers throughout India. Even Amrita Hospital is one of the pharmacovigilance centers. So it can be reported, and in what format it has to be reported. And before that, how it can be observed, because some reactions will be very much visible, but in some cases we have to be proactive to see that when all there is a chance for ADR. Like, see, if there is a drug added, or if there is a drug deleted from the patient medication chart, we have to be more vigilant that why it was deleted or why it was added. Maybe it is because of the adverse reaction of the previous drug, maybe some one new drug has been added. So we have to use some these trigger points to find out where there is a possibility of where there is a chance for ADR, and that has to be taken care. And we have to educate the patient, and we have to withdraw some drugs, or we have to educate him to see that he doesn't get into the adverse reaction. Okay, if the adverse reaction happens, how it is managed? We have to give lot of details to the organization, that is the Vigilance Program of India. What are the details? We have to first tell what type of drug, what was the suspected drug which was given, which has caused this ADR, what are the other drugs co-administered, and why it was given, and in what dose it was given, how long it was given, through which route it was given, and batch number which has caused this ADR, which has to be mentioned, because sometimes the same batch, when it is used, it always leads to adverse drug reaction. So this can be communicated to the supplier and the manufacturer, so that that batch can be withdrawn from the market. So these are all the things. And one important thing I have to highlight here is whenever the doctor prescribes, it is better that drug in brand name, it is written very clearly in capital letters, followed by the pharmacological name, that is generic name, can be written in brackets, so that the errors due to the reading can be eliminated. So I request, because this we do in prescription audit, and we always request the doctors to write the drugs in capital letters, so that many spelling mistakes or taking the medication, reading the medication wrongly, all this can be very much avoided. So this adverse drug reaction, any reaction, sometimes know that the healthcare team members feel that only the drug reactions to the newer drug has to be communicated. It is not at all like that. Even with the oldest drug, many new reactions are coming up. So that has to be communicated. Only when number of reports go to the center, there is a global center at Uppsala, that's called Uppsala Drug Monitoring Center. So that these centers will be receiving all reports from throughout the globe, and they will be able to take any action, whether any warning has to be mentioned in the label, or the drug has to be totally withdrawn from the market. All these decisions can happen only when we communicate to them, and in larger numbers. So many adverse reactions are happening in every hospital with every patient, but still it is underreported. So this has to be taken care. So time to time, training has to be given to the whole healthcare team members, and sensitization has to be done for the doctors. The whole, as a department, if you take doctors, nurses, pharmacists, and other people, sometimes physician assistants are also there. So all are involved in this healthcare team, in prescribing, transcribing. So everybody has to be sensitized how important it is to report the adverse reaction, because many times it can cause death even. So any serious adverse event has to be communicated to the manufacturer, to the doctor, to the ethics committee within 24 hours time. So this has to be taken very, very seriously, and all the reports. And here, adverse drug reactions, certain things can be reported by the nurse itself or the doctor, but I will better recommend that whenever there is a reaction, it has to be communicated to the pharmacist, so that because there are certain analytical work has to be done by the pharmacist, the causality analysis. So that can be done by the pharmacist by they're going through the literature and other aspects of drug administration, so that it has to be completed. If the form is not complete in all aspects, then it is difficult to take some decision whether the drug requires warning or drug requires recall or drug requires anything else or to be withdrawn totally. So all these aspects have to be taken care.
Yeah, thank you. I think a broader perspective of this is very much been placed. Thank you so much. I know it's this gamut of knowledge which is there, and the time is so precise, and I'm very sure this will help. So the allergy a patient may have. In fact, the chemotherapy drugs which the patient takes may also have toxicities post administration, not just during the thing. It can be post 3rd day, 5th day as well. So even monitoring of a patient back home also is an important element across over here, and reporting and managing it in the correct direction so that it is prevented for others, and recalls of the medication. So these are all things which people should know and be aware. Nurses should be aware so that they can pick up the things. Now when we're thinking about picking up the things, I request Ms. Madhavi to help us to understand what are these common reactions that we're talking about. What are these that needs to be at the bedside very easily picked up, what they should be sensitive about, what the nurses should be always looking forward to when it comes down to picking up these signs and symptoms. Ms. Madhavi, over to you.
Yes. Thank you for the question. Yeah. So when we just coming around, can you just please repeat your question? I'm so sorry, I missed the last part.
How do we look at this early and late reactions? What are these reactions which needs to be very much keen? The nurse should be keen in picking it up while medication administration is in place.
Okay, so thank you for that. Okay, so ma'am actually very wonderfully covered the adverse drug reactions. So when we talk about early and late reactions, the adverse drug reactions are the long term and short terms. The short term, when we see the short term reactions are easily be seen, like there is a rashes, itching, which is easily seen and captured by the bedside nurse. Okay, these are all the hypersensitivity reactions that are usually we trained our nurses who are privileged to do medication administration. So this is something that is actually they are trained and their competencies are checked for. So what we need to do is there in the training part itself, we need to tell them how to identify these hypersensitivity reactions. Yeah. This is very important, because when we do an onboarding process, we have a time when they roll in, we have these nurses who enroll with us, we do an induction, then we have an onboarding in the respective department before we privilege these nurses. So ADR is a part when we give them the privileging of medication administration. This is what we need to actually train them to actually understand and recognize the reactions, the early reactions. And when talking about the long-term reactions, or you say the late reactions, so these are again where we need to train them and make them aware that it can be anything. It can be the late reaction, can be a deranged RFT, LFT. It can also be hyperkalemia. All these kind of things where we need to, empower, make our nurses aware, our bedside nurses aware that these are some of the late ADR reactions that also can be identified. For example, even meropenem, when a meropenem, study says that in meropenem's late reaction is seizure. So everything kind of all things of the ADR, once we have a policy protocol saying immediate reporting. So once you empower the nurses, when you see the signs, immediate reporting of it. Yeah, stopping the drug, which already we know once we see something, the drug is stopped, all these. But this is again in the practice where instead of the nurse getting scared and there is a panicky situation, she has a written down and a structured protocol of identifying this N number of signs, symptoms, which are to be reported immediately to the treating doctor and the action to be taken. So that will actually help us, to take right step and empower our bedside nurses to take actions over the ADRs, the reactions of ADR. Thank you.
Thank you, Ms. Madhavi. Dr. Zaidi, what are the other points, as safety tips which people can keep in mind? Whatever we've discussed, other than these, are there more simple tips which can be kept in mind in order to prevent the medication errors?
So can you repeat the question, ma'am?
Yeah. So apart from whatever we've discussed, are there any more points which the healthcare professionals can keep in mind as safety tips, medication safety tips?
So, ma'am, I would like to emphasize only one thing here, that lack of communication. That is the main point of medication error, be it between the consultant and resident doctor, be it with the resident doctor nursing staff, be it with pharmacist, or any other person who is involved in the entire process. So communication is, if there is a lack of communication, if there is miscommunication, or if there
I think we lost Dr. Abbas. Okay, we'll just wait for him to come back. In the meanwhile, I would like to ask Ms. Sandhya. Yeah. Yes. In between, we lost you.
So, ma'am, I had already completed that communication is the, if we have lack of communication, there is a risk of happening the medication.
Right.
Yeah.
Thank you, Dr. Abbas. Ms. Sandhya, we would like to also have a knowledge understanding in terms of how do you calculate and capture medication errors, and what are the different indicators, quality indicators or KPIs that can be, kept as an organization to, ensure that these are being picked up and they are monitored and they are, well understood in the healthcare settings.
Okay, ma'am. So medication error rate calculation is the measure of the discrepancies between the medications that are ordered for the patient by the healthcare provider and the medications that are actually administered to the patient. So basically the calculation would be medication error rate, which is equal to number of errors observed divided by the number of opportunities of errors, that is doses given plus doses ordered but not given. So this into 100. So that is how we calculate the rate. Now coming to the indicators, the extracted quality indicators can be categorized based on structure, process, and outcome indicators. And if at all the data collection for these indicators are difficult, this might result in poor or insufficient data and an unreliable indicator. Though the indicator is there, if the data is not appropriate, it's no point in having an indicator there. So when selecting the indicators to be locally used, it is important for the endorsers and the users to critically review the quality indicators on acceptability, feasibility of acquiring the right data, reliability, sensitivity to change, and the validity of it. Now coming to structure indicators, it measures the structure indicators basically measure the environment such as the hospital infrastructure, the systems, determining whether healthcare institution has a policy and process of reporting and analyzing medication incidents, which would be an example of a structure indicator. For example, incident reporting and analysis, whether the medications are appropriately reported and whether they are analyzed. Similarly, having top 10 medications which are probably fall under a category of medication error, and also prospective medication safety analysis, which can be done once in a year, whether it is done or not. So basically this come under the structure indicators. Also, availability of high-alert medication is another aspect which can be categorized under the structure indicators, where we can calculate the number of concentrated potassium or availability of concentrated potassium on the floors, or is there a designated area? What is the policy that they are following? About narcotic safety, whether they are following the 3 very important criteria of having the prescription, having a double check during the administration, and also while storing it. And thirdly, the discard policy and the return of ampoules to the pharmacy. So whether they are following this or not. And coming to the second part, which is the process indicator, it measures the compliance with processes of care that have been shown to improve healthcare outcomes. An example of process indicator treatment would be example of anti-thrombotic medication for patients at risk of venous thromboembolism. So this can also be an indicator. For example, we can monitor reducing adverse drug events, where numerator would be the number of beds where the interdisciplinary team rounds are done and identified that these patients are on certain drugs and adverse reactions can happen, divided by total number of beds where the patients are actually the total hospital number of beds. So also it can also have visual reminders such as differentiating high-alert medications, where whenever a doctor prescribes a high-alert medication, there is a highlight or a flag raised, and also administering protocols for high-alert prescription medications, chemotherapy protocol also comes under this, where we can calculate the percentage of patients receiving cytotoxic medications against the total number of patients who have come for chemotherapy. The last one is the outcome indicators. These provide data related to the outcomes of care of healthcare system performance. An example is maybe the number of medication incidents that occur that result in harm, death, or per patient day of care. For example, especially under outcomes, we'll have adverse events, where we calculate the medication error rate for adverse events, where we calculate the number of rate means the measure of discrepancies, where we calculate the number of patient deaths, paralysis, coma, or other major permanent loss of function associated with medication errors, where denominator would be the total number of medication errors into 100. So these are few medication related indicators. I know very less time, ma'am, very vast topic this is. So I hope I've done
I think you went across on a very broad level. Thank you so much. It really gave the gist of it. I'm sure the listeners are going to go back and read to understand this more into the depth. So there's so many areas. So we understand this, that the KPI or the indicators are not just finding out medication errors in prescription dispensing, but so many areas are there which can be monitored and analyzed very well. And if they are there in the design inception phase itself, a lot of things can be prevented, right? I would like to put across the last question, but a very important question, and to a very important person in the healthcare process. That is, to the administrator here. How significant the leadership focus, in creating a culture of patient safety is there in preventing medication errors, and to create an environment which could be, safe for patients in this terms. Over to you, Ms. Leena.
Good afternoon, ladies and gentlemen. And Saino, that's yet another big question, and so much to discuss, and so many case scenarios which could be presented for all these. But I think I have only 6 minutes to go before you wrap up. So in a nutshell, what is an administrator's role? The first and foremost is to ensure a culture of transparency and reporting. So what exactly an administrator is supposed to do? She has to introduce risk register in the institution. She can get along with all the top leaders, especially the nursing leader. And just now, Sandhya has discussed about the quality indicators pertaining to medication errors. That is the first step. That is where we do our occurrence forms, our incidence forms. But what is the next is the risk register. So even before something would happen, if someone can capture it, that will be a very good initiative by the administrator. A very good example of that is my own institution, where we have a risk register and everything gets captured. All the near misses also gets captured on that. And people on the top layer, they're able to see all the risks which have happened in the hospital, especially the clinical. We have a separate one for the clinical and the non-clinical. And another example is when I was in CMC Vellore, I still remember the medical ICU head. He had kept a box there in the medical ICU which said risks. You can put in your chits into that. So anybody could drop their chit paper. They could just write without mentioning the name. They could just say there was a medication wrong dosage yesterday for so-and-so patient. They could drop it inside that. So it would be kept confidential. Who has written it, they need not mention, but who has done the error, they can mention. So that's one of a very good initiative which an administrator can put in place, and also encourage a system of root cause analysis and CAPA. Corrective action, of course, any drug error which happens, corrective action is first. But out of box thinking for preventive action is even more essential. All what the people at the bedside, they tend to think is education is the ultimatum. But the administrator can always tell that is not the ultimatum. They can also have some out of box thinking for preventive actions. And the third is non-punitive culture, not to punish any of the nurses or the pharmacists who make errors. Not to give them suspension or whatever it is, just to reward people who self-report. That is what happens in my own institution, Mehta Hospital. Every month I get 10 coupons. For those who self-report their medication errors, we give them an appreciation coupon. So the reporting culture has drastically improved. An administrator should also make sure that the brand freezing is there, not to have too many brands in the hospital and we'll end up not having what the doctor think. That results in omission errors, and also the license of the vendors, report the recall drugs and products, and to make sure that there is adequate tracking of all the quality indicators, especially stock outs. Are the nurses and the doctors comfortable at the bedside? Are they getting drugs on time? Why is there a deviation in the turnaround time for dispensing? What can be done for that? And excess stocking or understocking. This also is an administrative role. So all these things can be covered in the pharmacy and therapeutic committee of the hospital. When they all meet, these all could be discussed in that. And introduction of best practices like antibiotic stewardship. So we all know we are all almost going into the pre-antibiotic era, where there's so much of usage of antibiotics and we have nothing for our patients left. So administrator, again, they have to see that antibiotic stewardship is run by the HIC committee. Labels for infusion, even small initiatives like this can prevent big, very big errors. If chemotherapy is given, if they could have a orange label on the bottle, that could prevent a lot of errors. Adapting systems like dispensing robos, then cabinets dispensing, pneumatic chute system that could save manpower, that could fasten the process of nurses and doctors receiving the drugs at the bedside. If these can be introduced by the administrators, that would be a very good initiative for the hospital. And of course, Dr. Abbas has already told us capital letter writing. So this has to be a top-down mechanism. It just can't be done by a clinical pharmacist, or it may not be run by a nurse. It has to be a circular from the administrator requesting all the consultants to write their letters in capital, and also to introduce systems like computerized physician order entry, so that they type it out. And this is again HIMS driven. So it has to be someone who's on the top who's supposed to do this. This, of course, clears the pharmacist, gives clarity to the patient, gives clarity to the nurses, helps in reducing transcription errors at OP and IP setting. And barcode is something, again, an administrator is supposed to introduce. So there are a lot of stocks kept across the hospital, just not the pharmacy where it is licensed. But apart from that, we have got a lot of stock kept at each ward for the emergency use. So how are the nurses going to get replenished? How are they going to use this? How things are going to be good? Then again, barcode comes into place. That's again an administrator's role. And even small things, providing logistics for doctors and nurses to administer medication safely, as small as magnifying glass, because ampules these days are very small. Nurses are finding it very difficult to read, especially those who are 40 years old. Reading those ampules are very difficult. So providing magnifying glasses, then stickers for identifying lines, tubes, because they're not supposed to give anything into the arterial line. So are we giving them some color-coded stickers? And of course, what Dr. Narmada has touched on, look-alike, sound-alike, high risk. In what way are we touching on all these things? Then, of course, EMR and role of HIMS in preventing all these errors. Again, standing order for our nurses and clinical pathways revision whenever required, especially those which are having drugs. So I think administrator role is in short, to overlook everything what has been spoke till now. I think I'll end here.
Yes. I think a gamut of strategies are there when it comes down to creating a culture, because it is not just a one-day effort. It is ongoing effort on everyday basis. And these are so many things. The tips which you've given in terms of starting a risk register has been appreciated in the chat. They've just asked over there in terms whether the complaint box and the suggestion box should be separate. I'm sure. Would you like to address this? That there's a question there whether they would like to have a separate cell administratively.
The box was only handled by the HOD of medical intensive care unit. No one else would open the box and see the box, and he would keep it all confidential.
Yeah.
So if you want few people to look at it, you can still allow your risk register to be looked at by very few people. You can give them the access. Not everyone needs to get an access, and confidentiality is very important.
Absolutely.
And not to blame, game, or pinpoint a nurse. It's just to make a process change.
Yes, yes. Thank you for the question. I think the audience is very receptively looking and hearing it. Thank you so much for that question. One more question which has come is in, and I think Ms. Madhavi has answered very importantly at that point. And in case if you find an allergic reaction in patient post IV administration, who is accountable? Whether it's a nurse, whether it's a doctor, or any other person. And as Ms. Madhavi has directly, very rightly said, it is the why of the question to be answered and not about the who, unless the who is really, really accountable in terms of those errors. But when we looked at the ADR and we heard about it, we do see that, even regular normal things which are very regularly being used do get reactions around. Right. So reaction should be considered into, allergic reaction should be considered into an adverse reaction part. And from there that, should get into the reporting pattern. And then these should be gone into 5 whys pattern of, doing an RCA kappa of the incidents. This will help you to understand what exactly went wrong in the scenario. Whether it was the infection control practice, whether it was the fluid by itself, whether it was, all other aspects which Dr. Narmada mentioned about the ADRs, those aspects will be covered. Thank you so much for the question. I hope only these 2 questions are there in the link. We have already overshooted the time, but we are on time in light of how we started the webinar on. So I know, thanking everybody over here. Any more questions, we'll be more than happy. We'll take another half a minute in case if everybody would like to ask questions or, place any new question in the chat. Okay, there is one question. Some antibiotics, reconstituted or refrigerated, but it becomes colorless to pale yellow. Whether it is advisable to use it if pharma company recommends to use it. May I request Dr. Narmada to just answer this question?
Yes, madam. Yes, we are not supposed to use it because what was the original color? That we have to be noticed. If there is any change from the original color and the texture composition, it cannot be administered. It should not be administered. It could be because of the incompatibility reactions which has happened. So that should not be administered.
Absolutely. I think in the whole in this whole bargain, when these drugs are being shifted, also the cold chain part of the medication also is a very, very vital role when it is transit in between the distributors, in between the wholesalers, and also when it has been, there in your corridors when the medications are lying over there, the temperature which is supposed to be maintained for the medications have to be, kept in mind. So should not be used. Thank you so much. Any other questions, please? Okay. I'm very sure that this is a big gamut and everybody was able to bring down a lot of important elements from a safety point of view and did a justice in terms of everybody's roles. We all are important when it comes down to medication safety. Each and every one of us in our respective scenarios, in our respective roles should be very, very careful and vigilant in terms of looking at this perspective and contribute 100% in terms of preventing, because errors are preventable. These are something which is not required to happen, and we are dealing with the life of a patient. For that family member, for that significant other, that person is very important. We all are in a privileged profession to do something good for humanity, and and by any given chance our hands should not be responsible for any of these errors which can cause harm to any of the patients in our lifetime. So with this I would like to thank all the panelists, all the esteemed panelists who have taken their time, and they have really brought down their knowledge and their experience vast into this small gamut of capsules to take us. So let's take these capsules and make sure that it helps us all the way through, and this knowledge will go way along for all of us. There are students here, there are practicing nurses over here, and I request all of you that please take this as a message in terms of being careful and vigilant in all that you handle, in all that you do, and create a safe environment and culture around patient. When you are around, there should never be any harm. Thank you so much. And
one more question.
There is a question. Oh, very nice. Good. Yeah, we will take it. Role of clinical pharmacist in ADR. Okay, and yeah, I think this is the question.
Yes.
Role of a clinical pharmacist in ADR. Yes.
So a clinical pharmacist can identify once the reaction happens. He has to observe what is the nature of reaction. He has to describe it, and he has to see which are the drugs responsible for that. Whether they might be suspecting a drug, but what are the other drugs co-administered, and what are the condition of the patient which has led to this reaction. So here he has to analyze the causality association, whether it can be definitely related to the suspected drug or anything else. So for which we have to look, search for the literature, and if there are already reports saying that such reactions has already happened with many patients, then we can say yes, it is the suspected drug which has caused this problem. Supposing we don't have any literature support, then we have to say it can see there are some terms which are mentioned there, whether it is probably related to the suspected drug or is it possibly or unlikely. So these are the terms which are used, and there is a scoring, and we have different scoring scales like Naranjo scale, WHO scales are all there, Hartwig scale. So any of these, mostly we use WHO scale or Naranjo scale, and these scales have to be used to ascertain whether this drug, the particular drug, has caused this adverse reaction. So this has to be identified and communicated to the higher centers, and then it has to be taken care in the hospital setting that this drug is not given to the same patient in future, and an alert can be mentioned in the patient case sheet so that this patient is allergic or he has experienced this type of adverse drug reaction. So in future, we have to be careful in administering this drug or prescribing this drug to the patient or in a combination. And when we deal with chemo drugs before administration, every time the doctor insists on monitoring certain parameters. So before administration, we have to check whether those monitoring parameters have been checked, whether it is normal. Only when it is sure that all the parameters are in normal range, it has to be administered. Otherwise, it should be taken to the notice of the doctor what has to be done next.
Right. Thank you. Thank you. I think that answers the question, I guess. Thank you so much for the question, and thank you so much for the response. I think, Vijay, we have addressed all the questions which were there. Yeah. So I would like to again thank ANEI and AHPI and Microlabs for providing this platform for such a knowledge sharing for all of us. Thank you so much, and a very good evening.
Thank you, ma'am. I think we need to also thank you, Ms. Saino Thomas. I mean, it's a marathon session, trying to handle more than 5 panelists with all various spheres of experience. So I thank you for having spared your time. I also, on behalf of Microlabs, would be more than happy to thank all the panelists, Dr. Abbas, Ms. Madhavi, Ms. Leena, Dr. MP Narmada, and Ms. Sandhya, Rani. So thank you very much, all of you. And not the least, AHPA have been always encouraging us for such programs, along with this time ANEI. I'm sure we will continue to do more programs in future. But nevertheless, we look forward to meet you again tomorrow for our day 5 program, which is already designed. So looking forward to meet you once again tomorrow between 3 to 4. So thank you once again, all of you. Have a good day.
Thank you. Thank you, sir.
Thank you very much for the opportunity given.
It's a wonderful platform to be connected to you all.
Thank you, ma'am. Thank you all.
Thank you.
Thank you.